Hello, students. We're going to be doing chapter 13 today, preterm and post-term newborns. The preterm newborn, and I put this picture here specifically so you see this frog-like appearance. They don't have the same muscle tone that a term newborn does, and they have a very specific appearance. And preterm birth is one of the major reasons for our babies that are not surviving that first year of life. There's a higher percentage of birth defects, which may be the reason that they are preterm, but we do know that birth defects and preterm birth do tend to go together. And they have other risk factors that might affect them during delivery as well as immediately after birth. So gestational age is from the actual time of conception to the time of birth. And a preterm infant is anything less than 37 weeks. We like to talk about a late preterm, and that's somewhere between 34 and 38 weeks. That's really our late pretermer. We know that those babies have different conditions than our babies that are born at term. A term baby is 39 weeks and more, and a late term is more than 41 weeks, and a extreme post-term would be more than 42 weeks pregnant. And so back to those late pretermers, we are looking at babies that are usually out on the floor with their moms, but they have issues like not being able to control their temperature, not being able to take in enough food. They look like they're feeding really well, but they don't actually have the fat pads in their cheeks strong enough to pull that milk into their mouths, especially from the breast. So we have to be paying very close attention to our late pretermers on the floor. The early pretermers, before 35 weeks, are going to be in the NICU, being taken care of by that nursing staff. So how do we figure out how old they are? Well, sometimes people don't know when they got pregnant, or they didn't get prenatal care, and they don't remember their last period. And so we have a couple of tools that we can use. One of them is the Ballard score, and it uses characteristics and neurological development to try to determine, and we can get pretty accurate within a couple of, a week or two of where these babies actually are. So this is the scoring system. We're looking at neuromuscular activity as well as physical maturity, and we go down each one of these and rate the baby based on what we find. And so, like, for instance, this is the square window. So you look at that square window, that would give that baby about a 2. So by the time we add up the score, it gives us a gestational age in weeks to determine about how old this baby is. We're also looking at how well developed the baby is at birth. We will see that babies that are born prematurely have everything that they need to function, but those systems sometimes don't work as well. So we will have to help take care of some of those things for them. For instance, one of the things that we have to work with our premature babies is being able to maintain their temperature. They don't have the ability. They don't have the fat. They have a lack of subcutaneous fat. And so that doesn't allow them to burn up that fat efficiently enough to be able to keep their temperature up. Sometimes these premature babies aren't able to take in as much nutrition, like I already mentioned, and so they are not able to get what they need, and we have to help them either with IV fluid, TPNs, or with feeding, sometimes through nasogastric tube or an oral gastric tube. I have some pictures of that in a minute. So they have some different characteristics. You can stop this video and look at these characteristics. One thing I do want to point out is the vernix, which is that cheesy substance that covers their skin to keep them waterproof on the inside, has an inverse relationship to surfactant. Surfactant is that soapy substance in the lungs that keeps the alveoli open and allows a gas exchange to happen. And so if they have a lot of vernix, they have low surfactant. If they have very little vernix, they're going to have higher surfactant. So this is one of those quick assessments. If you have a baby born with a lot of surfactant, a lot of vernix, you're going to be looking to make sure that that baby's breathing well. And it might not start immediately. It may be over the next couple of hours that we start to see some respiratory distress. The other thing that we look at, which is kind of a quick assessment, is the creases in the soles of the feet. If a baby has smooth feet, we are concerned that that's a very premature baby. And the creases start to develop the more weeks the baby is gestational. The gestational age, as the gestational age gets higher, there'll be more creases on the feet. So if it's only 2/3, we know that that baby probably is more 34, 35, 36 weeks versus term gestation. So here's a picture of what a premature baby looks like. You can see they don't have the fat pad underneath the skin. This baby is modeling because it's cold, and is going to need some support, probably in the NICU, to maintain its homeostasis in its body. So again, inadequate respiratory function. That's one of the major concerns that we have with our premature babies. Their diaphragms aren't as developed. They don't have the respiratory centers in the brain as developed, and they don't have that surfactant. Here's another picture of a little preemie. This guy has some respiratory support through a high flow nasal cannula. It's getting fed through an oral gastric tube. Has its cardiac monitors on because this baby's in the NICU. O2 sats are here. All of these stickers and everything that's attached to this baby is made specifically for a neonate skin because their skin is very fragile and we can't just go peeling things off. So everything in the NICU is made for these purposes. So respiratory distress syndrome is one of the disease processes that we see in NICU babies. And it talks about surfactant here again. And we see this in babies that are usually in the 24 to 34 weeks, but any baby can have respiratory distress syndrome because even a term baby that's been exposed, that's had a very difficult delivery or has been exposed to infection could develop this. This is one of the major reasons that our babies end up going to the NICU. And so we have to support them by helping them to breathe, because if they're not able to make that gas exchange, then they don't survive. And here's a picture of a baby that's on a traditional ventilator. And then I put this picture here. This shows you the isolette. We will have to put these babies in an isolette, which is very much like a womb. And some of you that have been in clinic have gotten to come through and see these babies that are in these isolettes. And so we cover them up because we want it to be able to be dark in there, just like it was when they were inside the uterus. We decrease stimulation. We maintain the temperature inside. We even put a little humidifier in there to moisten the skin, keep the skin moist. And we're able to cover them up because they're on cardiac monitors, which is showing heart rate, respiratory rate, and oxygen saturation. So we want to decrease our stimulus of these babies in the NICU. We talk very low. We don't go in and touch them all the time, only if it's necessary. And we try to put all of our care of the baby in one particular time frame. So if they are being fed every 2 to 3 hours, then we will every 3 hours go in and do our assessments and change their diapers and whatnot, because these babies are not meant to be here yet, and their neurological systems are immature. And so we don't want to disturb that because it can affect their growth. And we have to teach our parents that as well. Parents sometimes think that these are just little babies and they act like term babies, but they don't. And they have different needs. And so we teach them to come in during our touch times and to talk very lowly when they are holding their babies. We don't do a lot of rocking back and forth. They can't handle that stimulus. Some of the signs of respiratory distress syndrome are the things that we've talked about. 60 breaths or more per minute, that's tachypnea. And then they might also be grunting, nasal flaring, have central cyanosis, have retractions, either intercostal or sternal. They eventually edema and apnea can occur as this gets worse, and we may have to put them on mechanical ventilation. So our nursing care is going to be monitoring those vital signs. Again, these babies that have already been diagnosed with this are going to be in the NICU. We're going to cluster our care, as mentioned, monitoring their pulse oximetry. They have a different pulse ox level than what we use as adults. We are perfectly happy with 88 to 94, depending on their gestational age. and we're going to be watching for signs of overhydration with these little guys. This is why being able to do the med math is so important. We give them IV fluid based on their weight, and we do that in kilograms to make sure that we're using very accurate measurements. Here are some of the respiratory support devices. This is a high flow nasal cannula. This is a CPAP, and they use both nasal prongs and a mask. It has to be changed every 4 hours or based on policy, because their little face and nose are so moldable and fragile. We can actually change the shape by using this equipment and cause breakdown. So we have to change this very frequently to make sure that we aren't causing any deformities in this baby. And then this is a traditional ventilator. So apnea in the preterm infant, this is another problem we see with our little babies. Sometimes they just have some apnea, and it can be accompanied by bradycardia. This is the reason that they're on continuous monitoring, and this is what one of those monitors would look like. Across the top, you see the heart rate. Here you see the respiratory rate, and here you see the oxygen saturation. This is a blood pressure, and yes, that's normal. This is their mean arterial pressure, and this is the baby's temperature. So this is one of the reasons that preterm babies are on monitors, because sometimes they have some apnea and bradycardia, and we have to go over and remind them to breathe. Their nervous system and brains are not fully developed, and this is one of the things that NICU nurses do, is watch for those signs and symptoms and then intervene. So sepsis in the preterm infant, this is infection in the bloodstream, and one of the signs of sepsis is low temperature. If they're not able to maintain their temperature, we're concerned that maybe it's because they're sick. They don't get high temperatures like adults do. They have low temperatures. And that's why it's so important to get an accurate temperature on these babies. They might be lethargic. They might not be feeding well. You'll hear them described by the parents as, oh, they're just so sleepy. They might have some respiratory distress and showing us some of those signs. So if we have any of these signs, we're going to go ahead and start treating and then look for other confirmation of infection. So we'll draw a CBC, a CRP, and a blood culture. Blood cultures take 24 to 48 hours to get results back. So if we have any signs in our CBC, like a high white blood cell count, or a left shift in their in the differential, or if we see an increased CRP, which is C-reactive protein, a sign of inflammation, we're going to go ahead and start treating them because we can't wait for those confirmation signs. If we don't start treating them very quickly, we may lose them because these babies have no reserve. This is a term baby that was born with no issues, and mother was GBS positive, and then within a couple of hours started looking like this. You can see the color is very poor, the tone is very poor, it's on a ventilator. This is a very, very sick baby. So we're going to start intravenous antibiotics. We're going to maintain warmth and nutrition. So we're going to do that for this baby that has sepsis. We're not going to ask the baby to try to manage that themselves. Very close monitoring of vital signs. These babies are going to go into the NICU, and we're going to be following standard precautions. Strict hand hygiene is essential in the NICU. So we make sure that we do not have our fingernails growing past the end of our finger. There is no jewelry allowed in the NICU, no watches. We put our cell phones in little Ziploc bags and keep them in our pocket. And then we scrub our hands all the way up to the elbows, including picking underneath every nail and scrubbing for 3 minutes. So everybody going into the NICU follows that same protocol, whether it be staff or parents. So signs and symptoms of cold stress would be decreased temperature, increased respiratory rate, sometimes with periods of apnea, bradycardia. This is modeling of the skin. You can see how this modeling is showing that this baby is trying very hard to maintain homeostasis, and lethargy. So we can actually have a baby get very sick very quickly if they are too cold. And again, hypothermia could be a sign of infection. So we're very concerned about the baby that cannot maintain its temperature. So our hypoglycemic baby, typically this is either going to be our preterm infant or our baby that was born to a diabetic mother that was not well controlled. And it, for your book's purposes, it's saying anything under 40 milligrams per DL for a glucose level, and in a preterm, anything under 30. So again, this is per policy, per hospital, and these things will be managed based on what those policies are. But it's very important for us to be watching. Now, any baby that's had a difficult delivery, or that's been under a lot of stress, or has had maybe a long induction and a difficult delivery, those babies are at high risk for hypoglycemia because they've used up all their reserves. So they don't, our babies have sometimes poor nutrition because they don't have the same stomach capacity. Their tummies start off the size of a cherry, so they're very small. If we have increased vomiting or increased regurgitation, maybe throwing up a lot of the fluid that was in their stomachs from delivery, that is an issue. And so we might have to support these babies, especially if they're sick or not feeling well or in the NICU. We might have to support their feedings because they're not able to take in what they need. Babies can't go a day or two without eating. They don't have the reserves that we do. They don't have the fat stores. So if you have a baby that's not eating well, that is a severe sign and needs to be looked at very quickly by going into, if you're at home, we tell the parents they need to go to a doctor right away and try to figure out what's going on, because we cannot let them go for several missed feedings. Bilirubinemia is one of the biggest things that we deal with. I highly recommend you go and watch the Prevent This video that's on the YouTube video list this week. It is was done. The video was made in the 90s, and it really talks about how we weren't watching for this and doing a very good job at predicting who was going to have high bilirubins, and it shows what the end result is. Kernicterus is the disease process that happens from the damage to the brain that happens from high bilirubin levels. So what bilirubin is the byproduct of breaking down these excess red blood cells. So the liver is immature, and it isn't have the ability to help clear this bilirubin out of the body very well. The way the body gets rid of it is through the stool. And so we want these babies to be taking in enough nutrition so that they can have lots of stools, so they can get rid of this bilirubin very quickly. Normal physiologic bilirubin, high bilirubinemia, happens over the first 3 days of life. And sometimes it's from not enough breast milk. There's not enough breast milk with the mother to cause the baby to have lots of stools. It's not breastfeeding that causes it, it's just not enough. So these babies are typically our poor feeders, the very sleepy babies, the babies that are having more than a 4-hour break in between feedings. And we want to encourage these mothers, especially if they have risk factors, we'll talk about that in just a minute, want to encourage these mothers to get that baby up to the breast as often as possible. And if the baby's not feeding well, then we hand express, get the milk out of the breast and put it into the baby. And then we have what's called pathological jaundice, which is not normal. This happens within the first 24 hours of life. It is usually from an Rh incompatibility or a blood typing incompatibility, the ABO incompatibility. So that's where mom, dad, and baby all have different blood types. So visual inspection is a very poor indicator of how high the jaundice is. The picture I have in front of you obviously is a very yellow baby, but we do not use visual inspection because every baby has a different rate of yellow tint to their skin. So we use tools to help with our inspection. So for our hyperbilirubinemia babies, every baby is at risk for this. And so we're going to be looking at risk factors. And I'm going to talk about risk factors in a minute. We are going to be looking at Rh incompatibility. And then we're going to be charting this baby's bilirubin levels based on the transcutaneous bilimeter and or blood levels. And then we're going to educate the parents on how they can help get this bilirubin out of the body. The number one way is feeding, feeding, feeding. Lots of feedings is going to get this baby pooping a lot, and that will help get rid of the bilirubin. Sometimes we have to move on into phototherapy, and the last ditch effort would be exchange transfusion, and I'll talk about that in a second. So our goal of treating jaundice is to prevent connectorus. And again, you want to watch that video, Prevent This, what connectorus actually does to the brain. It's toxic and it causes irreparable brain damage. So these are those Billy lights that I talked about. Sometimes you see a bed, sometimes you'll see a blanket. Here's a picture of a blanket. What the Billy lights do, this is a special kind of light. It's UVA light, and it is going to allow the body to change the bilirubin into a water-soluble compound, so now it can be urinated out as well as passed in the stool. So it changes it. This is not the same as sunlight. Sunlight is UVB light, and it does not change bilirubin into a water-soluble compound. So this is one of the tools that we might use to help the baby get rid of this bilirubin early on. So some of our risk factors for bilirubin are jaundice visible on the first day of life. Again, that's pathological. That's not normal. We normally see in normal physiological jaundice, we see it rise over the first 3 days. It peaks about the 3rd day and then starts to come down. Any sibling that's had jaundice would put this baby at a risk. If there's ABO incompatibility, RH incompatibility, we talked about. Baby's not feeding well, it's sleepy, it's not going to the breast very often, mom's using a lot of pacifiers, that will definitely increase the risk for jaundice. If they have a deficiency of the G6PD, that's going to be tested for on the newborn screen, so we won't know that right away, but that will increase the risk. If they have infection, if they're an infant of a diabetic mother because they have excess red blood cells, or if they're premature, those are all going to put them at higher risk for hyperbilirubinemia. If they've had a lot of bruising, if they have a cephalohematoma on their head, or if they have a high hematocrit, which is very common in our diabetic babies, they're going to have more red blood cells to break down. And then certain ethnicities will affect how much bilirubin is in their blood. So this is the graph that we utilize, and the graph got cut off, but we need to know how many hours old the baby is. So when we're looking at this graph, this number is only going to work if we are able to show how many hours old this baby is. So down here, let's say this is 24 hours old, and you can see if our bilirubin level is 7, we're immediately in the high risk zone. So we need to be graphing it based on hours old and where they fall. So we're going to be taking a very close look at what the trend is, so that the family and the doctor will have an idea of how what the risk factors are for this baby. So for instance, if this baby's in the low risk zone or low intermediate risk zone, we know that it's okay for them to be seen in about 3 to 5 days if they're in the low risk zone, and within about 48 hours after discharge in the low intermediate risk zone. If they're in the high intermediate risk zone, they're going to need to be seen within 24 hours after discharge to make sure that we are not trending into the high risk. Once we get into high risk, we're going to have to start some sort of treatment. And that would be utilizing Billy lights. And if they've already gone home, most likely that will happen at home, or they might be readmitted. So this is just a picture of the isolate. It's old word for it. It's an incubator. And this is just showing you how we kind of recreate a womb-like environment for these babies. We never tap on the glass or do anything like that. It's actually plastic, but we want to help these babies maintain a womb-like appearance. And so it manages their temperature, that we can cover this up and make it nice and dark so that they can continue their development. This is a radiant warmer, and babies under a radiant warmer either have healthcare providers standing right there with them, and it's usually used for resuscitation purposes. Sometimes we use it for a bath. And if we are going to step away, this baby cannot be left on this warmer unless we attach a temperature probe. We do not want to allow this baby to get overheated or even cooked. And so this is not the type of tool that we would leave a baby on. And sometimes if there's a warmer in the room, we have to make sure that the parents and grandparents know that they can't just turn it on and leave a baby on there. And then kangaroo care, we want babies, especially in the NICU, to spend some time with their parents utilizing kangaroo care. It increases bonding, and this is skin to skin. It's no t-shirt in between, and a lot of times people think when they put them skin to skin, they want all those cute little outfits to stay on. You got to take all that stuff off. A hat and a diaper is all they need. And it helps to calm the baby, calm the mother. It increases milk supply. It allows good bacteria to be transferred from the mother to the baby, helps to build that microbiome. Very important stuff. And here, this is providing nutrition to this preterm baby. Sometimes we have to utilize a feeding tube, and these are put in similar to how they're put into an adult. We do introduce a little bit of air to make sure that it's in the right spot. And again, we're using specialized tape to on their fragile little skin. But this is the kind of thing that you have to know for sure where this tube is before you start any feedings, because this could be very detrimental if it's not in the right spot. We utilize this type of feeding because babies aren't able to take in as much energy as they need. They use up more energy than they take in when they're very small. So this baby may have to be fed this way until it matures and is able to start utilizing the nipple. So our prognosis for our preterm babies is usually pretty good. They usually catch up by the 2nd year of life, but our very low birth weight baby sometimes will never catch up. We do see some long-term health issues. One of them is retinopathy of prematurity. It has to do with the eyes. Their retina is not developed when they're born extremely premature. And so the oxygen that we utilize to help save them actually affects collateral growth in the eye and can cause some issues with that retinal development. So they're going to be watched very closely for retinopathy of prematurity. But this is why you see a lot of these micropreemies have glasses as they grow up. And so that's one of the long-term health problems that we might see. Here's some more ex-preemies. So this was this little guy. He's doing pretty good. This is this little guy. He still has to wear oxygen, so he's had some lung damage. And then this is this little guy, and he's doing pretty good. So it's fun to see these ex-preemies and how well they're doing. So families are going to need guidance. They need to understand about the touch times and decreased stimulation, like we said before. Sometimes you'll see bonding can be delayed or interfered when the babies are in the NICU. Sometimes parents feel very inadequate because there's all this nursing care going on, and we let them know that we're just there to take care of the nursing side, but they're there for the emotional comfort for this baby. And there usually lots of concern on the parts of these parents, and we have to do lots of education and support. Now we're going to move on into the post-term newborn. Now this says born beyond 42 weeks. We don't see 42-week babies very often because these doctors are intervening long before the 42nd week. But the placenta does not function as well after a certain point. It can result in fetal distress. We see oligohydramnios, which is indicative of not having good placental function. The mortality rate is much higher, which is why we induce these women. This is some of the examples of what their skin looks like. As they lose that vernix, we see their skin gets peely. Okay, had a little glitch there. So I was discussing how a post-term infant, they've lost that vernix, which is that cheesy substance that allows them to stay waterproof on the inside. And as that goes away, we see their skin gets very peely. There's lots of cracks in the skin. So we have to maintain, we want to help them moisturize with some lotion that's made for them so that we can decrease the chances of bacteria getting in. The other things that we see with our post-term babies is asphyxia is a possibility, which is not enough oxygen at delivery. Meconium aspiration is a higher chance because they have more meconium as they are post-term. They don't eat as well sometimes. They have more red blood cells. Sometimes the size is so big that they're difficult getting out. We already talked about shoulder dystocia. And if they have had asphyxia, they have a higher chance of having seizures. So our nursing care is going to be just like with the preterm baby or even the term baby. We're watching for signs of respiratory distress, watching for signs of hypoglycemia, hyperbilirubinemia, and cold stress. So this is just I just put this picture in here so I could show you, if we have to transport a baby, they end up going in an incubator, a transport incubator, and they have a whole team of people that go with them, usually a nurse, a respiratory therapist, a specialized NICU nurse that travel with them. And so it can, and we do have a NICU transporter here in town where we move babies back and forth between hospitals. So whether it be the preterm or the post-term baby, any baby that spent time in the NICU, we are going to have to go through a discharge process. We're going to have to make sure the parents know what sort of special care they're going to need, if they are going to be having special follow-up, and we will definitely be talking about the signs and symptoms that they need to report. And we want to make sure that they have some communication either to the hospital. They can always call back. Social service usually keeps in contact with them. There are some support groups here in town for baby mothers with premature children. And then we want to teach them some good CPR techniques. We have them watch a video. We don't actually certify them, but every baby that leaves the NICU, their parents watch a CPR technique video so that they have an idea of what needs to happen if they start to have some respiratory distress at home. Okay, that's it for this chapter. If you have any questions, you know where to reach me.